In podcast episode number 49, I talked to Mike Ryman about femoral acetabular impingement, abbreviated as FAI. Mike is a physiotherapist, active clinical researcher, educator, and mentor with a special interest in the hip. He's also an associate professor at Duke University and an adjunct professor at Wichita State University. So what is FAI? It's a bony abutment of the femoral head against the acetabular rim. And there are two main types. When the femoral head is too large, we are talking about a cam morphology, which is more common in men. And an overextending acetabular rim is called a pincer morphology, and it's more common in women. There's also a mixed type, which seems to be the most common. Mike explained that it is suggested that this morphology develops as specific adaptations imposed to demands similar to throwers, which develop torsion of the humerus. During adolescence, it might be that the growth plate shifts, which renders the head less round, but larger. Once the growth plates close, the morphology is pretty much fixed. Mike then elaborated that several studies show FAI morphology in 40 to 60% of asymptomatic people and even 60 to 70% of athletes and non-athletes present with labral pathology already at a very young age of around 40. So lots of people have abnormalities, but only a small fraction develops pain. When asked if having FAI is a risk factor for hip OA, Mike mentioned that we actually don't really know yet, as there are not enough longitudinal studies out there yet that follow young patients for up to 20 to 40 years. Some studies do suggest that having FAI is a risk factor, but still the biggest percentage of people don't go on to develop hip OA. According to Mike, other genetic factors or rheumatological conditions might be stronger predictive factors for hip OA than FAI. So how do people with FAI present? Patients who suffer from FAI are typically patients between 20 and 40 years of age and present with deep-seated pinching groin pain, which might present with clicking and mechanical symptoms if labral pathology is present as well. A study from St. Louis, however, shows that some of these people also have lateral hip, buttock, SI, and low back pain, which makes a diagnosis challenging. According to the Warwick Agreement, there need to be three components. Patients need to have symptoms, clinical signs, and imaging findings to diagnose FAI. Then we moved on to diagnosis. During the subjective exam, Mike is trying to find out what triggered the hip pain, such as changes at work, activities, or during training. His focus during treatment then is also to modify provoking activities as a first step. The patients that have modifiable pain are also often the ones who have a better prognosis according to him. Then Mike focuses on impairments such as range of motion, including end feel and guarding, and he also evaluates muscle weakness, focusing on side-to-side differences with a handheld dynamometer. At last, he mentioned that it's important to have a holistic approach and to include psychological and social components as well. Mike has done a lot of research on the Fadius test, which, like he stressed, is a good test to rule out intra-articular hip pathology, but not a good test to confirm FAI. We also discussed how to differentiate intra-articular hip pathology from muscle injuries leading to groin pain, like described in a Doha agreement. He mentioned that intra-articular hip pathology is less common and that by prevalence alone, most people are going to fit within the Doha agreement. According to him, the mechanism of injury is a good differentiator, as well as relatively acute symptoms, like for example in an athlete describing a stretch mechanism. Furthermore, he would expect hip rotation to be provocative in patients with intra-articular hip pathology. On top of that, patients will probably show with limited and/or guarded internal hip rotation and a different end feel, which is often hard or firm. The C sign might be another indication for FAI in comparison with muscle injuries. The Thomas test might show with consistent clicking when the leg is lowered. Personally, he favors ultrasound-guided intra-articular injections that can confirm intra-articular hip pathology if patients experience pain relief for 48 to 96 hours. It can also be helpful if the patient has done X-rays in an AP or frog-leg view showing FAI morphology. We then went on to talk about the necessity of imaging. Mike mentioned that patients and surgeons would often want imaging, but that to him it doesn't change treatment in 99% of cases. So he would only refer for imaging in case he wanted to rule out red flags such as a slipped capital femoral epiphysis, abbreviated as SIFI, or if the patient is not progressing with conservative management. Moving on to treatment, Mike uses an acronym he calls EPIC Return. The E hereby stands for education. So he tries to help the patient to make sense of the condition and uses motivational interviewing to find out what the patient's goals and expectations are, and he tries to create a therapeutic alliance. The P stands for progressive loading. Mike explained that he first focuses on increasing a patient's work capacity, trying to get them more active by getting them on a bike or ergometer or having them walk, during which he measures their RPE. He also has every patient squat, and this is where the I for individualized comes in. Early on, he tries to calm down the hip by avoiding provoking activities. If squatting is provoking, he starts at 60 to 80 degrees of hip flexion or has them perform wall squats, isometric squats, squats in a Smith machine, and so on. The C stands for considerations, where he tries to answer questions like, am I the best physio to treat this patient? How many visits do they have? What does their insurance say? And so on. We also talked about muscle groups in the hip that we should focus on during treatment. While there are studies showing that the hip extensors and hip flexors might be important, Mike explained that he would usually measure strength in all planes and focus on the factor that he thinks is the biggest rate-limiting variable. Oftentimes, he will start in the frontal plane first, so with abduction and adduction, and then move on to the sagittal plane. He's also a fan of adding core work in the form of dynamic core exercises such as Pallof presses, cable or band exercises, as well as chops and kettlebell swings. Then we talked about return to sport, which takes an average of 7.5 months. However, we should differentiate between just being on the pitch or performing at the same level before injury. Depending on the patient, Mike generally focuses on different rehab phases. First, he usually tries to increase work capacity, then moves on to strength, and then to power, thereby decreasing the load and increasing the intensity. At last, we talked about the effectiveness of physiotherapy and surgery for FAI. There are a couple of studies suggesting that surgery is more favorable when we look at the outcomes after 1 year. At 2-year follow-up, there are no differences anymore. Unfortunately, we don't have any prognostic factors yet, which people might do well with physio and which people should go for surgery. On top of that, the problem with the studies evaluating physiotherapy is that they often did not implement the best practice. All right, this was a brief summary of podcast episode 49 with Mike Ryman. I hope I could raise your curiosity to listen to the whole episode to learn more about FAI. If you would like to have more resources on this episode, head to our website physiotutors.com, where you can download the transcript and infographic for this episode. As always, thanks a lot for watching, and I'll see you in another video